I just want to thank you all for joining us today. Um, we'll be getting started here. I think we have a great talk today about, getting you back into action. People with hip injuries, whether it's an injury, it's arthritis, it's stiffness and pain, or you're just not moving the way that you want to. Summit Orthopedics is here to help, no matter what your situation is. My name's Dr. Werner. We have Dr. John, who's going to be joining us as well. And I wanted to give you a little bit of background about us and Summit Health. So we're one of the Tri-State's leading providers in primary and specialty care. I think the great thing here is that, we have coordinated care. We have physicians in 80 areas of medicine, 340 locations, which I didn't even know it was that high. And, we're all over the tri-state. So New York, New Jersey, Connecticut. We're open 365 days a year with our partner City MD. So if you ever need urgent care help, there's always someone there for you. And like I said, we're a connected team here. So that's the best part. Our providers work together. We connect the dots between primary, specialty cares, urgent cares. And really, the nice thing is you think of your primary care doctor as your quarterback, your team leader. It's the NBA playoffs, maybe your point guard, but they can always hand the baton, and we work together in concert, which is always so great. I work in the Berkeley Heights location, and just in my building, we have so many specialties, and we're all connected. We're always available to each other, and I think that speaks volumes, and it's the greatest thing for our patients. So today I'll be leading our discussion. I'm Dr. Jordan Werner. I'm a board certified orthopedic surgeon. My specialty is in hip and knee replacement, so arthroplasty as we call it, and I'm in the Berkeley Heights location. Joining us today is also Dr. Thomas John.
Hey Jordan, thanks for having me. Good afternoon, everyone. It's an honor and a privilege to host this event this afternoon, and we're going to have a fun couple of minutes this afternoon, just going over a few topics, especially as it pertains to the hip. As Jordan mentioned, my name is Thomas John. I'm an orthopedic surgeon, fellowship trained in hip and knee replacement, and I have the privilege to practice out of our Hackensack, Montclair, and Fairlawn locations. And just as Jordan mentioned, our Fairlawn hub is also fully staffed with a myriad of medical specialties, and it's really made life that much easier for patient care and coordinated care. I'm also an assistant professor in orthopedic surgery in our Hackensack School of Medicine. So with that, let's get started, Jordan. All right, so I believe it's time for a poll. All right, so if you guys see the window that I'm seeing, I would like for you to navigate to this window, and let's open up with this question. How would you rate your understanding of hip injuries and conditions? 1, and this is okay, this is not a test, I promise, there's not a pass or fail. It's I have no knowledge. 2, I have some basic understanding but want to learn more. Or 3, I have a solid understanding, but I'm tuning in to learn more about Summit and connecting with the surgeon. So if you don't mind, just go ahead and click 1 and then we'll touch base. There you go, 73%. I have some basic understanding, but want to learn more. Well, guess what? You came to the right venue. Jordan and I are going to take some time and we're going to teach you what you need to learn.
All right. I think, it's a great thing. We have 45 minutes here to really talk to people. Some we might have seen in the office, a few we might have operated on, and some might be completely new to us. So, I think it's a great mix. I love, doing this in the office too. I'm, always talking with our patients, across a wide range of issues, injuries, arthritis, everything. So, it's nice to have this here as a forum with both of us here. I think it's great to talk to, a new group of patients as well. All right. So, we're going to be focusing mostly on hip arthritis. And, here's the background. These numbers are staggering. So 528 million people are living with arthritis. This is a worldwide problem. It's not just here, it's everywhere. And it's always increasing. So, it's way up over the past 30 years. And, it's predicted to go way up in the future. As you see here, 73% of people living with arthritis are older than 55 years old. That's not everyone, though. There are younger patients and younger people that are living with arthritis as well. So it afflicts a wide range of people, both young and old. And yeah, 60% are female. We see that about a 60-40 split. The hip is one of the most frequently affected joints. So the other two, knee and shoulder, two other commonly, treated ailments, and ones that we have great specialists, including myself for the knee and Dr. John, and shoulder, we have others as well. But, we see all these joints. And like I said, the prevalence is expected to continue to grow as time goes on.
Jordan, do you think the prevalence is increasing because our community is just getting more active? Why do you think it's going up?
I think it's many different reasons. So, these are mechanical joints, where I think people are living longer. I think people are becoming more active and they're staying active for longer. And so over time, we're seeing wear of the joints, we're seeing further arthritis, things also like obesity, genetics, which we'll get into later, but there's a whole host of factors that all factor into this and lead to an increase in arthritis in our communities.
Yeah, no, that's a great point, which brings us to this slide. What is arthritis? I get that question a lot. Is this arthritis or is this rheumatism? A lot of stuff, right? So break down that word osteoarthritis. So osteo refers to the word bone. The word arthra refers to the joint. Itis means inflammation. So this is a bone joint inflammation. Now that could be anywhere in the body, the hand, the knee, in our case, the hip. And so when we talk about the hip, and this is something we get a lot, folks come in, grab their waist or their lower back or the upper buttock. Guess what? That's not where your hip is. Well, doc, where is my hip? The hip joint is actually closer to your groin. And and that's very important. And so you'll say, well, that's not my hip. Well, that's where your hip joint is. Okay. So as it pertains to this talk, when you're referring to the hip joint, it's closer to the groin. And the hip joint has two basic parts. It's the top of the thigh bone or the femur bone. It's where the ball becomes the socket. And we refer to it as the femoral head or the head of the femur, and the acetabulum or the socket. Now, in a perfect world, you would have good covering of that ball with cartilage, like the end of a chicken bone. The problem is, like Jordan mentioned, as we beat it up, genetics, other issues, that protective cartilage wears off. And if you can see it on this x-ray, you're all going to be experts in x-ray reading at the end of this, but you should have space between that ball and that socket. But what's happening here, there's no space, and that space isn't air. It's that protective cartilage, and we no longer have that cartilage. So what's arthritis? It's really an umbrella term referring to a few things. One, no more space, so that bone is touching bone, right? So that joint space is narrowing. Now, this is where you get an element of physics. When the bone starts rubbing, the body tries to make extra bone to spread out the force. And then you get these bone spurs or osteophytes. Well, that will be good, except guess what? It's supposed to be a round on round, except now it becomes a square peg in a round hole. And that could be very disabling and can cause pain.
All right. So, getting back to your question from before, there's many causes of hip arthritis. And, I have patients every day that ask me, what is the reason I have this arthritis now? And it's multifactorial. It's not one thing. There's patients who are quite obese, patients who are very thin, patients who are young, patients who are old. So there are many factors that go into it. Like we see here, lifestyle factors, excess weight, obesity, which, the nice thing is as people lose weight, it's about 4 pounds of pressure off their hip and their joints. with each pound that they lose. Also, injuries, older injuries, newer injuries, they can lead to arthritis over time. As as Dr. John covered with all the anatomy in there, you can damage the cartilage, you can damage the labrum, and it leads over time to worsening of this arthritis. And then overuse. We're all very busy and working and running around and on our feet all day, and over time that can wear out the joint. Like you said, it's a ball and socket. So this is a mechanical joint that can wear over time. Age, yes, it's more likely more years in on these mechanical joints that you can wear out the cartilage. Gender, postmenopausal women have higher rates of osteoarthritis. And then genetics. There is a component of genetics. It's not necessarily, my mother or father had it, so I have it. But, there is a component that plays in here that's always being studied. Developmental abnormalities, and then autoimmune. I mean, there is rheumatoid arthritis, which can certainly play a factor in here to wear and inflammation in that joint over time.
Yeah, Jordan, I just wanted to add, previous accidents, right? I mean, one thing I see a lot in our society, especially the younger kids, they're very active in sports. It's great, but they get hurt, so trauma is very important. Previous accidents on the job. So I think there are just, to echo what you said, just a lot of things that kind of go into this.
Yep. I mean, one of your slides from later, it'll show, trauma, previous hardware, things like that lead to wear of these joints as well. So, and whether you had surgery or not, I mean, I saw a patient the other day, they had an unknown injury about 50 years ago. They were just placed into a cast, and now they almost have a fusion of their hip. So, these things have consequences down the road. All right.
So this, yeah, go ahead. This X-ray, just to kind of highlight what we saw earlier, you can see that stark difference I was mentioning before, right? On the left, you can see a ball and a socket and a lot of gap in between the ball, and that's a normal hip joint. And on the right, you see an X-ray where the cartilage is completely worn out. And so we don't always get advanced imaging. In our office, usually X-ray suffice. I mean, Jordan, do you find that in your practice you get a lot of advanced imaging? And when is there a role for such imaging?
I completely agree. I mean, I think that a good set of X-rays in the office is, for 95+% sufficient. There are cases, when the story is just not making sense. You're not seeing terrible arthritis, but the patient's in terrible pain. Maybe we get an MRI to take a look. Maybe there's a stress reaction or a stress fracture. So, I've seen that, and I've had several patients that we've operated on, stress reactions, and you do a hip replacement and all their pain goes away. Those are some of my happiest patients, and those are ones that sometimes we'll get a CAT scan or an MRI for. But, I think a good, 3-4 view series is definitely sufficient. You see a good AP, a good lateral. I think that's the way to go.
Yeah, the only thing I would add is, I know MRIs is kind of like the gold standard, and a lot of folks, the first visit will sometimes insist, "Hey, doc, are you sure you don't need an MRI?" And I get it. In our day and age, a lot of stuff you find on the internet. But when it comes to arthritis, unlike other conditions like Jordan mentioned, most of the time an X-ray is all you need. But let's say you fell and now the pain is going on for weeks. It's not improving. Well, guess what? Now we're suspecting something else, maybe a hairline fracture. Or if you're on the younger side and you have hip pain, well, could it be something more subtle like a torn labrum? Then it's appropriate to do an MRI or a CAT scan. Remember, this stuff has radiation if it's a CAT scan, or it can add a lot of expense if it's an MRI. So I think really consult your doctor and make sure it's needed.
Agreed. So let's get into this. So there's a lot of non-surgical treatments for arthritis. It's not just you come in the office, we see arthritis on an x-ray and we jump to surgery. That's not what we do. There's a lot of conservative treatment measures, you know, lifestyle modifications, losing weight. Like I said, 4 pounds of pressure come off your hip with every pound that you lose. It's a huge factor. Physical therapy, keeping stretching, strengthening, those are two great things for your hip. Um, Anti-inflammatories, Tylenol, things like that, prescription pain relievers, can be helpful too to decrease the inflammation in that joint. Yes, cortisone injections are used. In the hip, we only use maybe one or two and really see how that works. But I think it's a powerful tool because it can help us make the diagnosis. Sometimes it's hard with hip and back pain to delineate, and injections can certainly help putting that injection into the joint. Um, Exercise, low impact exercises, good gentle range of motion, stretching and strengthening. And then the use of an assistive device, a cane, a walker, things to offload can certainly be helpful.
What happens when none of that stuff works and you're struggling? Right now, we talk about surgical intervention, and this is where first you start seeing someone in the office, like one of us, and we talk to you, we examine you, we put our hands on the hip and check the motion, we check x-rays. Once we determine that surgery is the best option, you sit down with one of our surgical coordinators. At Summit, we have specific coordinators. This is what they do. We have nurses that are part of our staff. We have dedicated staff that will make every step of your journey very intentional, very coordinated, and we'll literally hold your hand. And after that, we coordinate a visit with your primary doctor. And if you need additional workup, let's say you have a heart problem. A lot of folks are on, have AFib or on blood thinners or have kidney issues. We'll make sure you see those specialists just to make sure nothing else needs to be optimized prior to needing surgery. You have to get necessary blood work. Again, we coordinate that with your primary care office. It's very important on number 5, if you're on things like blood thinners, like aspirin, 1 week before, you've got to stop it. Same thing with Plavix. A lot of folks are on things like warfarin, at least 4 days before, you got to stop it. Things like Eliquis and Xarelto, at least 3 days before. So otherwise, you don't want any bleeding risks during surgery. And a lot of our facilities offer what's called a joint camp. It's essentially an educational session where, look, we talk about a lot of things in the office, but there are a million things that these sessions discuss that make your recovery a lot easier.
And I think this is, this is the meat. This is what people want to know, especially when they come in. So how long is the surgery? Approximately 1 hour. The anesthesia is a spinal anesthesia with sedation. No heavy general anesthesia, no tubes down your throat. That's great because, general anesthesia can take a lot out of you, and it can take a long time to really wake up and come back to yourself afterwards. So the spinal is fantastic. The good thing is you can immediately put weight on your hip. You can start walking, you start therapy the day of surgery, and you start doing stairs as well. So people that ask me, I live on the second floor, you can walk up those stairs. You'll go slow, but you do it. Same day surgery versus an overnight stay. In the hospital, I think it's nice to, stay, do a couple therapy sessions, and then go home. But we have some very motivated patients who want to go home the same day, and I think it's fantastic. The first 2 weeks, we generally send a therapist to your home to come work with you, work on your stairs, make sure that you feel safe at home. And then you go to physical therapy after your first post-operative visit. In terms of driving, it's an important one for people. Generally, I think the textbook is 6 weeks for driving, but that's more for a right side where you got to be able to start and stop quickly. On the left, I think, it's probably a little bit sooner. I tell everyone, come see me in the office at our 2-week visit and let's see how you're doing. And then usually I think you're also back to work in, around the 6-week mark or even less than, and for some people. Certainly, people that are doing remote work nowadays, I think you can get started as soon as you feel comfortable. You got to be off the pain meds because we don't want you sending any weird emails. But besides that, you can remote work as soon as you can. And then in terms of approaches, so, I generally employ the anterior approach. I think it's a great, powerful approach that, we've developed over time. It's not a brand new approach, but it's one that's become popularized because our patients are doing so well. So as you see on the left, it's a pretty small incision over the front of your thigh. The nice thing is, as compared to some other approaches, we're not cutting the tendons around the hip. We're really, as you see on the right side, we're moving the muscles to the side and we're working between them. And it's nice because afterwards, those muscles go right back and it allows you to get up and start moving them pretty quickly. You have many fewer restrictions. You don't have to sleep with a pillow between your leg. You're allowed to cross your legs and sleep however you'd like. So, these are great, powerful things, especially in your early recovery to get you moving again.
Yeah, just to echo what Jordan mentioned, that's a very important thing. These surgeries used to be very maximally invasive, and now really we're kind of mastering the minimally invasive. And it's not just the incision size, which arguably, 3 to 4 inches, but really the tissue trauma inside. And sometimes you do have to go from either the side or slightly towards the back. Not all apples are apples, right? So some things are going to be oranges. And you can see just a high view of these x-rays. Sometimes folks come in with previous hardware. Like I just changed a person yesterday who had screws in for a fractured hip that didn't heal. Those need to come out. Or some people are born with hips just didn't form properly. Or redo surgery. They get a little bit more complicated. Or if you, God forbid, break something. And so, again, we have full access in our armamentarium to do these surgeries safely. And oftentimes, even after these complex surgeries, getting them up and mobilized the same day. Next slide.
All right. And so the nice thing is, as we move on, people ask me all the time about technology, what's improving, what's changing. And I think, especially on the hip side, there has been a lot of advancements. As you see in these pictures, there's special tables that we use. With the approach, we can use different robotic or navigation technologies, which are really helpful. And even that we can use x-ray throughout the case to make sure that everything looks great before we leave the operating room, which was something that we couldn't do in years past. The top right picture is a picture of the HANA table that is specially geared for the anterior approach to assist in surgery, which I use every day and I think is a very powerful tool. Also, I use computer navigation. So, that allows me to plan my surgeries beforehand. And then when I'm in the operating room, I can check my plan and make sure that everything looks great. There's also, like we said, robotic technology and such. One thing, like we talked about on the 2 previous slides, were the approach. So anterior versus posterior approach. Like I said, I do mostly an anterior approach, but as Dr. John said, with redo surgeries, hardware surgeries, not everyone is a candidate for it. So I will use the posterior approach for those type surgeries as well. Also body habitus. When I'm doing the anterior approach, I'm working near the belly, near the groin crease. So in some patients that have kind of an overlying belly or just tissue that I don't feel is a good environment, that's probably not the right patient to do an anterior approach. So that's when you can consider a different approach as well.
Yeah, just to echo what you said, Jordan, we have access as part of Summit Orthopedics. All of our joint replacement surgeons have the ability to execute these surgeries, and we have access to really a wide array of orthopedic technology like robotics, whether it be through Stryker or all the other major orthopedic companies, computer navigation, during the anterior approach. And really, you don't have to travel far and wide and cross a river into New York City to have access to this like folks used to historically. We have this right in your home, in your backyard. And I think that's really the distinct advantage of coming to Summit Orthopedics and seeing a specialist like myself or Dr. Werner because you'll get the same expert care right in your home backyard, and you don't have to leave more than 5-10 minutes from where you live.
And so this is the final product. I mean, this was a patient who had very bad hips, was severely debilitated, came to me almost in a wheelchair. And as you see on the right side, well, center is my implant, which I use for the anterior approach. And then as you see on the right, he has two well-functioning hips. He's gone completely back to work, and he's one of my happiest patients. So I just wanted to show this as really, really, a beginning to end story, which was great.
And then what happens afterward, right? You go through one of these surgeries. Let's say you take the leap of faith and you trust one of us and bless us with the opportunity. Well, guess what? We're not going to leave you hanging from day zero. As soon as you're done, once the anesthesia wears off, we have a team waiting for you at the facility. Oftentimes it's a physical therapist, an occupational therapist. They're going to get you up and moving. I always tell my patients, this is not a lay in bed surgery. We got to get you moving. That's the whole point. Remember, you're not sick. You just got a bum hip. So we get you up and moving the same day. We strengthen your muscles. And look, you've been walking all your life. We're going to get you walking again. Low impact activities. People ask, listen, what can I not do after? I keep it simple. Low impact. Look, can you run? Sure. But is it recommended? Not really. You want these implants to outlast you. These are fake parts. So that's the only thing. But low impact, like walking, bicycling, swimming, even cross-country skiing, no problem. And we stay connected. Like I mentioned earlier, we have nurses, we have physician assistants, we have our whole team waiting for you. You access us through the Summit Health portal, which is a computerized system, or you pick up your phone and call. We don't want to leave you hanging. We want to make sure you're tended to and your recovery is seamless. And like Jordan mentioned before, at 6 weeks, most people turn the corner and kind of resume their lives.
Yeah, I just want to echo what Dr. John said. We are always available for you. So, you're not doing this on your own. You're not on an island once you leave the hospital or the surgical center. We are there for you. Both the surgeon, we have our PAs, our nurses, everyone is there available to you. There's always someone on call. There's always availability to us, and we're here for you. So, some people, especially those, they live at home, they live alone at home. It's a very nerve-wracking thing to do this because they think that they're on their own, but they are certainly not. So I just wanted to echo that. It's a great point. All right. So let's take a step back. Let's answer some questions for you. There's a lot that's come in both beforehand and what you dropped in the Q&A box. If you have a question that you haven't asked yet, you can certainly continue to send those in for us. But let's touch on a few here. So first question, many patients report groin, thigh, or lower back pain. How can you differentiate between hip pain and other conditions like sciatica, spinal stenosis, knee issues that might mimic hip symptoms? Dr. John, you want to tackle that?
Yeah, like I mentioned earlier, groin is a interesting location, right? There are a lot of things in the groin, and it's important that we differentiate it. So you come in, first thing we do is a physical exam. If you have great range of motion at the hip, that's one thing. But if it's limited, it's leaning towards a arthritic hip. And then we correlate that with an x-ray. Does the joint have a lot of x-ray changes? Is it radiating towards the buttock? Oftentimes, sciatica-like symptoms tend to start in the lower back, goes down the buttock, and it travels down into the foot. And hip pain, on the other hand, usually starts in the groin, can circle around, but it stops at the knee. It doesn't go past the knee. It's very important. Now, I've also had patients, as I'm sure you've had, Jordan, they come in with vague knee complaints, but it's actually coming from the hip. And that's because the same nerve that supplies part of the hip comes all the way down to the knee, and you get referred pain. And then you can have other distracting issues like inguinal hernia. You have ovaries. There are a lot of things that can potentially be in the groin. But again, that's why it's important you come in, have a physical exam, get some pictures, and we can sort that out for you very easily.
Yeah, I couldn't agree more. And it's always so odd to the patient when they come in and they really are convinced it's their knee, it's their knee, it's their knee, and then we get an X-ray and to show them it's their hip. Referred pain is really a powerful thing. So, and we do see it quite often. All right, let's try another. So I'll tackle this one. When is it time to consider a hip replacement? Are there clear signs such as pain level, mobility issues, or failed conservative treatments that indicate surgery is necessary? Well, it's a combination of things. And what I tell my patients is it's a quality of life issue. So, is it just pain? Is it just mobility? No, it's not one factor, right? I always will employ conservative measures. So, like we talked about earlier in the talk, physical therapy, home exercises, anti-inflammatories, maybe an injection. When these things don't work and, you're out there every day and, work is getting harder for you, or your activities are getting harder, or you even enjoy taking a walk with your wife and you can't do that anymore, it's affecting your quality of life. And if you've exhausted all conservative measures, I think that's when we discuss surgical options. So we never do it right off the bat, but when you need it, we have a great solution and great providers here, and we're always happy to take care of you. All right. What non-surgical treatment options are available for managing hip pain, including bursitis, arthritis, and tendon-related pain? And are these treatment options effective? Okay, Dr.
Yeah,
John.
so look, we've covered a lot of these things. So obviously bursitis and arthritis are different issues. Bursitis, a good rule of thumb, if you kind of put your finger right over that pointy part on the outside part of your hip, that tends to be a bursitis related pain. Those usually are because you have a tight muscle that runs on top of it and that causes a lot of inflammation. So stretch, stretch, stretch. Another tool that we employ often in our orthopedic office is a cortisone injection. If that doesn't work, there are modalities that the physical therapist does, not just to stretch and put you on a bike, but they can use treatments like ultrasound. There are some more experimental treatments like laser therapy and shockwave therapy. And these are things that your local physical therapist can talk about more, but I think these are important things. Now, arthritis, really the treatment options, you want to make sure you're not developing a limp. And oftentimes what happens when you have a limited joint, your muscles get weak. So we can't let that happen. We got to get your glutes nice and strong, maintain a good walking habit, and make sure your balance is not getting out of whack either.
Couldn't agree more. All righty, let's try another one. How can patients manage pain and stay active if they're not ready yet for surgery? What are the best exercises or stretches to protect and strengthen the hip? So, this is a very common one for people. It's hard to make that leap to say, okay, I need surgery. So, there's a lot for conservative management to try and stay active. I think in terms of exercises, stretching and strengthening are two of the most important things you can do. So a lot of people elect to do it on their own through walking, going to the gym, trying to do exercises on their own. But also we have many excellent physical therapists, both in our group and in the surrounding towns and areas that can help you with that. And I think, working with a physical therapist or trainer and such are extremely helpful and powerful tools to at least keep you going before you need surgery on the hip.
Yeah, the only thing I would add to that, I tell all my patients, pick a low impact activity. If you can make one investment, get a stationary bicycle. It does two things. It keeps that joint moving. A joint in motion is like lotion, so it keeps it less stiff, less painful. And if you can't get your hands on a stationary bicycle, at the minimum, go for a walk, just a flat surface. That's very important. In terms of exercises, doing clamshells are very important. The figure four stretch, where you strengthen the back of your hip. So these are very simple things you could do at home.
Okay. And then there's let's get into a few of these questions. We have a few minutes here. Okay, here's one. For minimally invasive, do you have to cut the muscle or just pull apart to gain access to the bone joint area? So, like we talked about, there's many different approaches to the hip. There's a posterior approach on the back side, a lateral approach is on the side of the hip, and then also anterior approach. I'll tackle anterior approach, because that's what I do mostly. But for this one, we do not cut the muscle or any of the tendons around the hip. What we're doing is, after we make the skin incision, we will pull those muscles to the side using retractors to gain access to the front of the hip joint. Then we go through the capsule, which allows us to get to the bone, and we do our work through there. The nice thing is we do a lot of work through a pretty small incision. I always say the incision is what it needs to be. So, if it has to be a little bigger, that's fine. However, really, we do all of it through a pretty small, minimally invasive incision.
Yeah, another question is, can both hips be done at the same time? That's a great question. I think that, listen, can you do it? Sure. Do people do them? Sure. The higher in the body that you go where you do joint replacement, the risk profile goes up. So risks of heart attacks and strokes do go up higher. So I do not recommend doing two joints at the same time, especially as it pertains to hip replacements.
Yeah, I agree with that. I think it's hard. I think it's a real recovery for the patient, either side, and then you do both at the same time. It's a lot of surgery. It's a bigger recovery. I think some of my happiest patients are the ones that I actually discussed breaking it up. And by the time they get to the second one, they know what to expect. I think they recover quicker and they're back on their feet. Although it is two separate recoveries, the second one, I feel like they fly through, which is nice. All right, here's another one. How long does the replacement last, or the range? And this is a question that I have in my office every single day. So the good thing is, and also people ask me, are the implants good? Is the technology good? Should I be waiting to see if something comes down the road? I just had this conversation about an hour ago with a patient. So I think we're at a very good time for hip replacements. I think the approaches are good. I think the surgery is, well done and perfected. In terms of the implants themselves, so the plastics that we used to use used to wear out in about 10 to 15 years. So that's why, we said, wait as long as you can, kick the can down the road, so that hopefully you don't need a second surgery. What we're seeing now is the plastics, they have more bonds and they're lasting longer. We had all the plastics in the hips changed about 20 years ago, or 22 years ago. And there's good 20-year data coming out now showing that we're not seeing the wear rates like we used to. So what that means is younger patients and patients that want to be more active, I think it's okay, if they need the surgery, to go ahead with it, because we're seeing longevity with the implants, and it's allowing people to be active for longer portions of their lives, which I think is fantastic.
Yeah, another question, I think, Jordan, that's a good one. Are you ever worried about failure after surgery due to osteoporosis? Do you need medical management for osteoporosis before a hip replacement? I think that's a good question. Oftentimes, unfortunately, our average age tends to be 50 to 60, but they get even older, and naturally, as you get older, the bone gets weaker. Osteoporosis is, again, to review, is that condition where the bone quality is getting weaker. So it's not as strong as when you were a little kid. And yes, this is a open surgery. There's no question about it. Even though we use words like minimally invasive, it's a big deal. And we have to put in a hard metal against a soft bone. And so there are risks. Now, treating osteoporosis, unfortunately, it takes a long time. It can take years before that can be corrected. And oftentimes, folks just can't wait that long in terms of their pain relief and function. So the answer is no, you don't have to wait for full treatment of osteoporosis. However, if you've identified it, like getting a bone density scan that you would do through your primary care doctor, you should definitely get on treatment, and that should be done concurrently while also pursuing a hip replacement.
Yeah, I agree. That's a great question. I think it can take a while to improve osteoporotic bone, and sometimes it's, kind of ran into an osteoporosis range, which is really hard to treat. I agree. I don't make patients stop for a full course of treatment, but if it is identified, I definitely think that treatment should be employed beforehand. I think that's good in general for bone health. Um, I think with the medications and such out there, we are seeing improvements. There are risks to some of the osteoporotic medications. However, I think the benefits outweigh the risks. Obviously, that's a conversation for another time. You could have a whole talk on that, by itself. But we are in the surgery. Let's say we get to that point. We're very careful, handling the bone and in what we do. And also, if the bone quality is poor when we get in there, there are things like cementing a stem in place, which decreases fracture risk. Or sometimes we'll put a cable on the bone to protect it while we for putting in the implants and for afterwards to help with the stresses in the bone. So there are things that we can do as well. Okay, and then all right, let's do it. Let's do the poll. We answered a lot of questions. There's so many good ones that we could just keep going here. Um, okay, so poll number 2. What feeling best describes how you are feeling right now when it comes to hip pain and existing treatment options with Summit Health? All right, good. 77% said informed. So
I
that
think
means,
that's a B, right? Is that a B?
is that a
Is that a B plus?
Yeah, that's pretty good. The nice thing is here, I think people are more informed in a 45-minute session. And also there's people that are wanting to learn more. So, myself, Dr. John, and all of our specialists, we're here for you. So we hope you do want to learn more, and we hope you come and see us. Truly, thank you so much to all of you for attending. Thank you to Dr. John for putting this on with me. I think it was great commentary and a great talk, and I certainly learned some stuff. So I hope everyone else did too. So, thanks for joining again, and I hope you learned something. And come see us.